Hi, and welcome to Quality D, where we are exploring quality in emergency care. I'm the host, Arjun Venkatesh, and I'm joined today by my co-lead in the Emergency Quality Network Stroke Collaborative, Dr. Corey Zackerson from MGH. And today we've got a special guest, Dr. Adam Oostema, who is not only an emergency physician and not only a stroke researcher, but he's also the lead EMS consultant to the state of Michigan's pre-hospital stroke program. And so it's a really great guest to talk about today's topic, which is thinking about quality of pre-hospital stroke care, how we can connect that pre-hospital environment to our work in the ED, and use that as a way to really drive better stroke outcomes in our communities. Adam, welcome to the show. Thank you for joining us today. I got to say, when I knew that you were coming today, I was thinking about sort of the world of EMS and pre-hospital medicine. I think on one hand, we feel like we are working hand in hand with our EMS community because we see medics every day when you're in the ED and you see the next patient get dropped off or another patient get picked up. On the other hand, it sometimes feels like we're in a little bit of a silo. We're talking a lot about what's happening new in stroke care and thrombectomy and lytics and different stuff and here on Quality D, but we haven't had the chance to really think about what's happening in that pre-hospital space, what's happening to patients, from the moment that they have those first symptoms. What's your sense of what's like, what do we have, what haven't we heard about, what's going on in that silo over that last year?
Yeah, I think that's a great point and a great question. Obviously, fragmentation of emergency systems in general was identified a long time ago by the Institute of Medicine as one of the big problems that emergency care needs to solve. And I think silos is the right word for how things operate from that point up until now. In the world of stroke care, I mean, I think this sort of boils down to there's two very different administrative structures that oversee pre-hospital care and in-hospital care. And so I guess the way that I have experienced it over the last couple of decades is that those two systems operate mostly in parallel. Our stroke efforts when we're doing quality improvement work in the hospital really start at the moment the patient checks in, and rarely are deeply engaged in anything that happens prior to arrival at the hospital. Um, on the other hand, in the world of pre-hospital stroke care, I think there's been a lot of activity and interest in trying to contribute more significantly to how stroke systems function. And some of that is just a general recognition that EMS adds something important to the processes of care that lead to a good stroke treatment outcome in the early setting. But a lot of that is also focused around how to get people to the right resources, given that not all stroke hospitals are able to deliver the same levels of care, and different stroke patients need different things. The whole large vessel occlusion question and how to get people to endovascular therapy has kind of really risen up as an administrative question and a quality improvement question and an organizational question that I think in the ED, as day-to-day clinicians, we're not very engaged in that, or maybe we don't even need to be, but there's a whole world of debate about how to appropriately triage, deliver, and otherwise kind of manage the transportation of stroke patients out in the world. So I see these as still two very separate things that have not found a good way to be part of a continuous kind of quality improvement infrastructure that's looking at the whole big picture.
Makes a ton of sense. I was pleased at the International Stroke Conference this year that actually one of the events on the main stage was related to pre-hospital care. And so I think it just affirms what you're sort of saying also, which is that everybody's recognizing that the pre-hospital space is an important place for us to be thinking about and addressing our attention when we're wanting to improve stroke systems of care and getting patients to the right place and doing the right thing sort of from the start. We've talked about variation in emergency care delivery and sort of variation in resources between emergency departments a lot and how that impacts the way that we deliver stroke care. But I also think that that exists in the pre-hospital space and maybe even to a greater extent, between whether stroke patients are transported by BLS versus ALS, different state policy and regulatory environments. Just like, I mean, I will tell you clinically, anecdotally, we can totally tell the difference between which EMS service is bringing a patient in based on like the quality of their pre-hospital call and like what they've done and what they haven't done in the way that they're like talking about the patient. So your work has shown variation between EMS agencies and the way they're delivering care too, and I think a lot of what you're trying to do is to address that. So I was hoping you could maybe talk us through sort of what that landscape looks like and how you're thinking about it.
Yeah, I think one of the reasons, both for the disconnect between the hospital and the pre-hospital setting and the variation that exists in the pre-hospital setting, is that EMS systems are inherently extremely heterogeneous in our country based on the resources that are available, based on the types of programs. So as a result, I'm always a little hesitant to make any broad sweeping statements about EMS anywhere other than like the places I can touch, because things are so different. So EMS is, in terms of its oversight and infrastructure, differs region by region and state by state. In Michigan, for example, we have kind of a centralized protocol sort of oversight body, but then a lot of the individual decisions about care are relatively local, with kind of consortia of EMS agencies and hospitals that then oversee the local protocols. And within those local agencies and local medical control authorities, you might have a group of private EMS companies that are providing contracted care. You might have municipal EMS agencies that are being operated and paid for by the local government. You may have even some volunteer elements to that. And so you can imagine just trying to get all these different infrastructures and all these different models and all these different levels of training to do the same thing is inherently challenging. And so, yeah, in the work that we've done, especially at the state level, we've been just very interested in trying to get a sense of how much variability there is. And so what we've tried to do is sort of pick things that we think are in compliance with our protocol and are good ideas for stroke care in general in the pre-hospital setting, and then make some group level comparisons across the state of Michigan. And what we definitely have found is that there's a wide range, but that the range of differences that we see don't follow an obvious pattern. It is not necessarily so that the biggest agencies provide the best care and the littlest agencies, don't. It is not necessarily so that a rural locality might have a massively better or worse sort of quality measure profile than an urban situation. And so that unpredictability just adds to it kind of defies an easy blanket solution. It's hard to target the problems. There's probably a lot of things that go into that. A little bit of it, it has something to do with training and level of training, which is a hard thing to get at from state level data sometimes. Who exactly was calling the shots at a particular pre-hospital run? It definitely has something to do with the motivation of a locality in engaging with EMS, particularly around a specific condition like stroke. It probably has something to do with EMR structure and how well it facilitates good documentation around certain things. So, as nice as it would be to just take our quality measure performance at face value, there's probably some amount of disconnect between what shows up in records and what, really happened on the scene. And so I guess all of those things I see as contributing to the heterogeneity. It's an inherent property of our system that it is heterogeneous. And so it makes it, sometimes challenging to come up with a one size fits all strategy to address all issues.
Adam, you just mentioned training, and it got me thinking about there's been a nice series in a lot of the lay press over the last year about what is essentially a crisis in the EMS community nationally when it comes to staffing. And so if you look at almost any EMS agency around the country right now, they have large vacancy rates, really high turnover over the past couple of years. And it got me thinking a little bit about this idea of it's probably similar to the challenges we are having in emergency nursing and a lot of other healthcare in a lot of other healthcare jobs right now, where you've had this kind of combination of high vacancy and high turnover. We essentially have a new healthcare workforce in many communities and in many areas. And I think EMS is probably one of like the quintessential examples of that. That's hard because it's not just about training stroke. Now we got to train back up the skills around STEMI care, around a variety of other things. And so if you're in a community that has experienced that kind of change in your EMS workforce, what's the most important thing when it comes to stroke care? Is it that you have a, screening protocol and everybody knows how to do a basic EMS screen? Is it notification and just having good communication systems around that? Is it none of those things and basically say, okay, if the gestalt is that there might be a stroke, we need to just work on that immediate to CT protocol. But my guess is that a lot of people are struggling with, you can't do all these different things, and you've got a relatively inexperienced workforce. Like, what do you do first?
Right, that's a great question. And I'm glad you highlighted that problem because it is a severe problem. And I think it is a problem that maybe disproportionately affects rural communities as well. So in my clinical practice, I spend much of my time in the city in a tertiary care center, but I spend a good portion of it out in a rural center. And boy, I'll tell you, we feel the lack of EMS personnel out there the deepest. And it is also makes questions about how to handle stroke even harder. When you have a very limited number of EMS resources, you have to be cautious about how you utilize them in the setting of stroke. So that problem is a known issue and something that is probably key to any meaningful like big picture change in how EMS functions for any condition. Specifically for stroke, though, like I think on the plus side, maybe the most valuable thing that happens in the pre-hospital setting for a stroke patient is recognizing a stroke patient. And so I think the stroke screening tools are fine things to teach, but honestly, I think giving EMTs and paramedics some of the background knowledge of when I should be thinking about stroke, a sudden neurological change, some specific features that are typical of a clinical presentation for stroke, providing them with that background and those tools may be the most impactful thing that we do, because once they're on a pathway of stroke, whether it's just communicating to the hospital via medical control, or the common sense of like, I'm going to let the hospital know that there is this thing. Many of the good things that happen in pre-hospital stroke care almost just flow from the fact that the stroke was recognized in the first place. And the data would at least bear out that if you look at all of the different quality measures that we've considered in Michigan, the single one thing that is the strongest predictor of better, faster hospital care is actually EMS recognition of a stroke versus not. And that's true even after adjusting for the obvious confounding stuff like, was the stroke obvious? Was the stroke severe? Did they have typical symptoms and so forth? So I think in terms of like, how do you train up a brand new paramedic or EMT and give them the tool that they need to do stroke care well, maybe the first and most important thing is just giving them a nice solid core of data about what they should be looking for when they're seeing a patient with an acute neurological change.
No, that's helpful. And I think, it's interesting because what you describe is something that can be done through probably existing bread and butter local EMS operational and educational programs. Versus, I think some of the more, there's a lot of emphasis and attention to some of the things around information transfer between EMS agencies and hospitals. And, even we as a big system that's well resourced are struggling to, pay for some of those types of IT tools. But it's like you said, those are probably secondary. That's the icing on the cake. You got to get the recognition down first. And that's something that I think in most communities, you've got a lot of ED directors and EMS directors who are well engaged in doing that sort of day-to-day education of EMS professionals.
Yeah, I think the monitoring infrastructure and the nuance of what we should do in certain circumstances, that's stuff that can be hammered out in protocols and pushed out relatively easily. But so one of the other hats that I wear is I'm the medical director for a EMT and paramedic education school in Grand Rapids. I'm a big believer that these students want to learn that stuff and they're able to pick it up, and based on my work educating, practicing paramedics and EMTs. If there's one lesson we learned from our one sort of citywide measured intervention on education, is that we could move the needle on recognition noticeably with nothing more than a good lecture on how to recognize stroke. Sustaining that, of course, is maybe where all the other parts of this come rolling in.
I think that actually probably gives you a really valuable perspective in your role as medical director, because you, I'm sure, understand and see the breadth of everything that pre-hospital providers have to learn, and in such an abbreviated time. And so could you talk through sort of what are the key points that, recognition, obviously, like, that's been like well established. What are the other things that like every EMS provider should know when you're talking to them about stroke?
Yeah, absolutely. When I'm doing that type of education, I guess the general themes are, when to look for stroke. So I think between dispatchers and EMS providers, we don't have a serious problem with paramedics and EMTs overlooking a person with dense unilateral weakness. This is not the patient we're missing, right? So over and over again in our monitoring work, what we see is that general weakness, unexplained fall, altered mental status. These are the situations in which we tend to overlook strokes. And based on a deeper dive of those folks, a good portion of them do have an identifiable unilateral neurological finding if it were looked for. And so when I talk about stroke, I usually, obviously review sort of the general pathophysiology and clinical presentation of a garden variety anterior circulation stroke. But then I usually emphasize, that not all stroke patients are this obvious. There's a wide spectrum, and then I try to highlight circumstances where one might want to look for a stroke. For example, unexplained fall, generalized weakness, altered mental status, and going actively thinking about it and asking the patient to lift their hands and smile and go through the process of a brief neurological examination can catch a chunk of these folks. But beyond sort of the initial who do I screen and how do I screen them education, I guess the other things that I emphasize are in line with what the general guidance is for pre-hospital stroke care. These things are generally enshrined in the protocol anyway. But I always emphasize that if there's one stroke mimic that we can identify in the pre-hospital setting, it's hypoglycemia. And bonus, we can also treat that one. So I usually lean heavily into let's make sure we screen everybody for hypoglycemia. Based on our statewide data, the incidence of hypoglycemia in a run that is dispatched for stroke is about double that of a run that's dispatched for anything else. You put everybody else in a pile, it's about twice as often, which is not super often, but it happens. So I highlight, it's not just stroke we need to worry about, it's also hypoglycemia. And then the rest of the education has to do with how do we make the process move faster? So once you've identified a stroke, we want to get off scene as quickly as possible. B, we want to gather some important information that's going to help the hospital decide what to do, like last known well. And then C, we need to let the hospital know before we get there so that they can get their system. And I provide a little punchline of like, here's why it matters. And then I kind of explain briefly how hospital systems operate differently. And then I usually show some of the data that we have that shows that those stroke patients who arrive by EMS with pre-notification have about a 30-minute faster door to CT time. I try to impress upon the students recognizing stroke is somewhat challenging, but when you think about it, you can find many of them. You should look for something else. You should do the things that are necessary to speed it up, and here's the payoff. And I find working with pre-hospital folks that understanding the payoff is a great motivator for doing stuff. One of the reasons I like doing EMS is that my experience is the average EMT or paramedic is trying to facilitate the best care for some person. They're very motivated intrinsically to do the right thing. And so being able to demonstrate how the right thing is a payoff for the individual is a big motivator in my experience.
That's a great example. I love that 2-to-1 statistic. Not just for the EMS community, but I can imagine many times using that, educating within our own ED amongst our nurses and folks, because too often do you get a groan when you ask for to get a blood sugar, because everybody thinks, anecdotally, that it's so rare that somebody's going to be hypoglycemic. But that's a really interesting fact. In fact, we should turn a little bit maybe to the hospital side of this, which is a lot of attention and a lot of our listeners on quality or medical directors or quality directors. And so the sort of partnered EMS intervention that's gotten a lot of attention over the last couple of years has been the idea of getting patients directly to the scanner when they come in with EMS. And on one hand, that sounds like it's very doable operationally in the ED, but it can be tricky. You have to figure out how to, still get some amount of a triage assessment, make sure somebody is safe to go directly to a scanner quickly. And it really, really is dependent, it feels like, on a lot of working with your pre-hospital team so that they're identifying people who should go straight to the scanner. And then the hardest thing I actually think nowadays is that you're tying up that team a little bit longer. And onload and offload times are a real concern in our EMS communities with shortages. What's your thought? Are these direct to CT protocols, like, are they worth the effort? What's the evidence sort of show around them? And you know, as our sort of listeners are thinking about this, you know, what are the key elements to making them successful?
Well, it's another great question. It's a hard one to give an easy answer to, though, unfortunately. What little evidence exists actually comparing like immediate to CT's protocols versus others would suggest that there's not definitive, there is no definitive evidence that that is in fact faster. Anecdotally, though, and in doing quality work with the state, and interviewing different hospitals, those who have these protocols and they work well swear by them. And there are definitely hospitals where it seems that there is an unnecessary delay to that CT scan that could possibly be addressed by doing it. As one anecdote, back in the early 2000s, I was involved in retooling our stroke protocol at that time to try to get our door to needle times under 60 minutes. And so we proposed that as an idea. And the very first patient that we ran through had a hemorrhagic stroke and wound up having to be intubated in the scanner. And so, like everything we do in emergency medicine, we're sort of like sifting through many patients who are likely to do fine on the regular pathway to find the couple of patients who don't do well. And so I get the caution that some hospitals may have about wanting to ensure stability before they go to a rig. I think things that facilitate at least having a coherent protocol are having a close enough relationship with EMS and a good system for gathering information about what EMS is doing to be able to put numbers around how often are we going to overcall it, how often are we going to undercall it, like are we actually putting the people in the CT scanner that we really want to put in there? I think just having numbers can be very helpful when you can get them to make a coherent decision and have everybody say like, okay, yeah, we get that, you know, this many of the people are going to come through and they're not going to have a stroke, but we're going to tie up the scanner for that time. I haven't heard much pushback from EMS about that. As a matter of fact, most of the time what I hear from EMS is they want that kind of thing. You know, it's a visible sign that they're being listened to and that their advice and impression are being acted upon. And so most of the feedback I've heard from the EMS side of things about a door to CT protocol is positive. When I hear trepidation, it's usually on the side of the emergency department. So having some data to understand, you know, what the likely impact of such a thing is, and maybe some data around like how often does it actually occur that a person comes in as a suspected stroke and EMS vital signs are stable, and then they decompensate in the time that they're in a scanner, and you wish you were in a different room. That's a pretty small number. You know, I guess I can't say a blanket recommendation about are these things definitely the answer. Perhaps they are. I think there are hospital systems that don't use that system and yet achieve very good door to needle times. And there's not really a one-to-one correlation between door to CT time and door to needle time. There is some variability in that. So I'm a bigger fan of what works for a system and less of a fan of making a broad statement about we should definitely be doing this or that thing. But on the EMS side, my experience has been they're generally pro that. I've never heard anybody say, boy, that's going to take us too long to get out of the department. Although those are obviously concerns as well. So I guess that's my 2 cents on that.
But I can also imagine it also building those protocols and actually executing them does probably build even better partnerships between EMS teams and ED teams, right? It becomes less sort of scoop and run and then drop off and go. And it becomes a little bit more integrated in that care moment. And there's probably some different benefits to that in care delivery too.
I imagine that's probably true. I think things that promote the two different silos to be around one table talking about things are probably of themselves valuable, whatever the outcome of that discussion is.
Well, we've also noticed that like the EMS providers like care about what happens to their patients, right? Like sometimes for their real sick patients, they'll stay and, you know, do their run sheets and document outside the room for a few minutes and kind of watch, and they're interested in what happens. And so keeping them engaged in that door to CT process gives them you know, sort of another opportunity to be around a little bit longer and to sort of watch it play out, which, you know, I think is related to the idea that they're all sort of hungry for feedback, and that that's a place where we probably could do, you know, do better.
I think that's absolutely true. Yeah, I mean, any interviews that we've done with EMS providers around sort of what they would like to see differently, one of the outcomes of those has always been we want to know what happens to people. If we're doing something wrong, we want to know that. And if we're doing something right, it's nice to hear back. And getting good feedback in a timely manner into the hands of pre-hospital providers it's a challenge, and it's not done well, I think, in the vast majority of locations. And even for those of us, like, we try to do that, but often the feedback will be limited to, say, somebody who got a thrombolytic or somebody who got an endovascular intervention. And that feedback is then given sometime after the fact. And it is nice. I don't think there's anything wrong with that, but I'm not sure that it really motivates a change in behavior. The most useful feedback is probably for cases that were missed but could have been identified. That's probably the most actionable feedback that we can give. So we tried that. And the problem was it took us about 3 months to collate the data, get it written up into reports, and get it out to people. And by that time, I don't know about you, but for me, 3 months after I've taken care of a patient, my memory is pretty foggy about what happened that day and what the details were. And I don't know that it necessarily impacts me the same way as maybe even immediate feedback in the ER of, boy, this patient looks like a stroke. Let's activate the stroke team. That type of feedback is probably something that is more able to help the learning process and help somebody develop their clinical acumen a little bit.
It's like that's the same true for emergency department quality improvement, where we know that when we give feedback, there's sort of giving it in multiple ways and multiple channels is the only way to really drive improvement. And so even if you're doing a stroke quality improvement initiative within your ED, being able to give people case feedback, case outcomes in a timely fashion on each case can be helpful, but it's usually coupled with those bigger aggregate quality measures. And so in the pre-hospital space, NEMSQA, the National EMS Quality Group, they've developed a couple quality measures, but they've been around for a while. And I think there's, limited time, limited people. And so collection of some of these quality measures can be burdensome in the pre-hospital space. Are there one or two metrics that you think are the important ones if you're a medical director for your local EMS agency and you want their stroke work to be aligned with what we're trying to do in the ED?
Yeah, I mean, in terms of quality measures in general, we're kind of stuck with observational data here. We have to look at what are the things that we think are most powerful logically, and then what are the things that we can actually measure that line up with that thing. The only quality measure for stroke that came through was the pre-hospital stroke scale documentation. And I think that's a fair one. It's well motivated. There is evidence that using stroke scales versus not using stroke scales is probably associated with more recognition. But the trouble becomes, who are we monitoring this in? So the easiest population to get pre-hospital data on for stroke monitoring is suspected strokes. And to me, there's a logical flaw in the idea of looking at stroke screening in patients we already suspected of having a stroke. If they failed to document it, but they called it a stroke, I guess I don't know what that means. Much more powerful, I think, would be, what is the pre-hospital stroke scale documentation rate among the patients that we missed? If someone did a pre-hospital stroke scale and it was negative, they've done their job. I don't think we can expect them to catch every stroke. So, but pre-hospital stroke scale as a measure in the population of transported strokes or missed strokes, I think is a great measure. Another measure that I think is maybe relevant, whether it was suspected or not, is the pre-notification metric. Certainly, that's one of the more powerful predictors of things happening differently. It is the only logical way that EMS can really influence the way things happen in the ED differently. If they get the system operating sooner, surely that must be the most powerful impact they can have on at least the very immediate rate. And as a matter of fact, Dr. Zacharinson's work would suggest it may even lower in-hospital stroke mortality. So the fact that we have that level of a good outcome associated with an action taken in the pre-hospital setting, to me, that's probably a top priority for a good target for measuring. Interestingly, that is one of the metrics that is most difficult to measure in pre-hospital data because it is documented so variably. It may be hidden in a narrative. It may map or not map to the appropriate sort of NEMSIS box. When you look at the data in aggregate at a state level or a national level, it's an interesting observation that it is both probably the most powerful thing that we could monitor as a marker of quality, and is the thing we have maybe the least reliable data on. The way we get around that is we use the hospital-based documentation of pre-notification from the stroke registries. But in order for that to be useful, you got to be able to link the two together. So that's a challenging one, but I would argue is probably one of the more important ones. Another one that we've focused on quite a bit in Michigan is glucose documentation, just because of the fact that it is so easily to capture. It is potentially impactful, not for the stroke patient, but for the non-stroke patient who looks like a stroke. And so I think those are the three that we've probably put our most effort, our greatest effort into.
That's helpful. In some ways, the studies that you talk about and these measures, they're all getting to this broader idea with stroke around the art of the possible. I think that for probably too long, we have sort of wedded ourselves to this assumption that little that we do can change stroke outcomes. Many of our interventions have marginal impact. You can identify and diagnose a stroke and you want to miss the diagnosis, but we can't really change what happens with that patient. I think again and again and again, we see that that's not the case. There's wide variation in stroke mortality. There's wide variation in functional outcomes. And just because we don't immediately see that, whether it be in the ED or the pre-hospital space, it doesn't mean that many of our actions don't have a huge influence on what ultimately happens with the patient days to months later. And that recognition, I think, is really helping motivate better stroke care in a variety of places.
Sort of nihilism of maybe we can't really change this is, it just doesn't it doesn't sit well, and it's verifiably probably not true. So going back to this idea, one other thought I have is that we've been shifting a little bit, rather than focusing on individual measures, to looking at overall quality in some way. What we have found is that if we kind of look at different elements of our protocol as quality measures, there does seem to be almost a linear relationship between performing these actions and the outcomes that we expect to see. So in a case where we do all the things we would ideally do, things go really well. In a case where we maybe only do one of our actions, things do less well. A paper that we just recently published that I think is maybe a path forward is trying to think of EMS quality of care as a broader thing than just a list of specific elements that are independently associated with good things. So there may be some role to look at a more global assessment of care.
It's great. Thank you. It was wonderful having you today. I feel like we covered a ton of ground, ranging from metrics to protocols to what's going on in the EMS workforce, training programs. And so this was a wonderful discussion. I really appreciated having you here with us today. I know I learned a lot, and I'm sure our listeners did as well. And hopefully we'll have you back in the future as we learn more and more about what we can do to sort of, like you said at the beginning, cut down those silos and keep bridging between the pre-hospital world and the ED world to improve stroke care. Thank you, Adam.
Thank you so much for having me.